Jon, so nice to be here with you this morning.
Thanks for having me.
In a few minutes, we're going to talk about physician as patient, because that is definitely one of your areas of expertise and a place where you are going to give us a lot of insight. But first, I want to give a bit of backstory in terms of how it is that we ended up having this conversation today.
Okay.
So we were talking about doing maybe exploring a project together.
Yes.
And I was sharing with you how I've made some changes in my clinical work because of a health condition, colitis. And when I shared that with you, I was surprised by your reaction.
To tell you that I had colitis as well.
Yes. Because we always think it's just
me,
us.
or or nobody wants to hear about that. It might not be surprising that I first started to have symptoms during medical school, like right at the beginning of medical school, or probably just before. And I wouldn't say that people brushed it off, but people just thought I was an anxious medical student. Of course, my stomach is going to be bothering me. I don't know how graphic I can get, but once you start, there are clear signs that this is not irritable bowel at some point. They just made the diagnosis, and I guess I've had it for. I'm going to age myself here, but I think it's 30 years or more. It has its periods where it's quiet, and then it reminds me that it's still there.
Don't forget about me.
Yes, misses me and comes back.
Back.
Yeah.
Let's talk a bit more about your work at the OMA. What is it that you are tasked with doing there?
So I'm the medical director for the Physician Health Program. We are responsible for 4 main pieces of work. So 4 streams of work. So we provide a lot of education around physician health. We advocate for physician health and well-being. We provide assessments. We monitor physicians who are in need of kind of an intensive case management when they have accountability needs. And we also have an intake service where we connect physicians with resources. I think we probably make about 1,000 connections a year. It's a lot.
So when you look at, all the work that you've done looking after physicians and how that sort of interfaces with some of the things that you've observed in your own life as a patient, where are some of the hot spots there?
I'm very mindful of the risk of minimizing or downplaying and making all sorts of assumptions that somebody already knows what I'm talking about because they're physicians, right? I mean, that's what got that's what got physicians in trouble, and why physician health programs started in the first place was because there was this assumption that, well, physicians know all this stuff. They should be able to take care of themselves. And that was not true at all. It was also very unfair, right? So also the idea of chronicity. It's not really a one and done for most things, especially mental illness or substance use disorders. So
when you look at the physician identity and some of the things that perhaps tend to define us either as personality characteristics or as things that we adopt once we join this profession, where are some of the major tensions that you observe as a psychiatrist?
People have a very hard time letting go and switching roles. I was going to say as well, this is a novel thing for me. I'm usually the one doing interviews, and they're probably for a reason, right? So there are features or characteristics typical of physicians that are going to be with us. Control, perfectionism. There's the compulsive triad, I think that was described by Myers and Gabbard. Yeah. So don't test me to remember exactly what it is, but I think it's an exaggerated sense of responsibility, self-doubt, and guilt. And those are significant drivers. But in terms of making the shift from being a doctor to being a patient, I think all of those things are still at play. And I think it's hard for the physician treating another physician to also navigate all of those complex feelings and experiences and the change in the dynamic.
Let's talk a bit more about that. So for physicians treating physicians, what other advice or counsel do you have?
Be patient with yourself and your physician patient, and don't assume. And be very respectful of allowing your physician patient to keep their white coat off and be a patient. I think that's the most important thing. You can engage them in a conversation about what treatment you propose, but don't ask them don't involve them so much in the decision making beyond what you would with anybody else.
Don't remind them of being on rounds, essentially, and quiz them.
Right. Oh my goodness. Yes. Because once that happens, you never forget it.
So, Jon, back to that point you made earlier about how physician health programs originally evolved.
Yeah.
When we think about the ways that some of us and some of our colleagues maybe still seek care, the hallway consult, the curbside consult, could you talk a bit about why that's such a problem for us?
It's a big problem because, you might get immediate access to, let's say, expert advice, but it usually doesn't come with any follow-up. So you're still sort of, left somewhat feeling abandoned, let's say. It doesn't allow you to establish like a long-term relationship with somebody who's going to continue with it. And it feeds the minimization, and it also puts your colleague in a somewhat awkward position too, vulnerable. People have written about how people do get really good care, but there is no follow-up. Do you really want to deliver the news of a test result in the hallway?
It's like a strange world colliding, right? That we just want to avoid that to the degree possible.
Well, it does. Both parties are sort of diminishing the significance of seeking help, getting help, and whatever it is that you're seeking help for.
Another thing I find myself thinking about is when you talk about minimizing. Yeah. And there's this interesting concept of physician-centered framing. So many of us, we have the worst reference points. We know the most catastrophic things that a headache can signal, for example.
Oh, yeah.
And so when it's not the most catastrophic thing, maybe it doesn't matter.
Right.
Could you talk a bit more about that? Maybe even how that's played out in your own life as a patient?
Oh, yeah. I mean, I will say, I think they're ridiculous things, actually. If I'm having a flare-up, let's say, and I'll say, well, at least I still have my colon. Okay. That does not mean that it's not signiant that with my colon, I'm still spending most of my time in the bathroom all day long.
It's kind of a low standard, actually.
Yeah,
I still have the anatomy I was born with.
Yeah. So I was thinking about this. And I think that I don't think it's just about physicians. I think it's there's something about medicine in general. There is a tendency to minimize, especially when it comes to mental health, actually, and substance use, where we almost require people to sort of either fail or to sort of outpace their treatment before they get something that really, really works. I mean, it's like, when was the last time an oncologist, presented to somebody with cancer and said, do you want the gold standard? Do you want the sort of like C or B level treatment first? We'll see how that goes, and then we'll give you the good stuff. So I told you, now I'm on Humira, which has literally been a miracle for me. But it took a long time I had to get worse and worse and worse before somebody would dare to put me on it. And, I could have been well for 5 or 7 years before that. No, nothing against the people who finally did. Actually, I'm quite grateful to my gastroenterologist, may he rest in peace, who took that brave step. But I don't know if I answered your question. But
well, you did. And actually, what you also made me think about, Jon, is, I've sometimes wondered, with medical exceptionalism and sort of the way that we see ourselves as the historical influences of that, our denial of basic physiologic needs as it's manifested in our training and our practice. There are times when I've wondered, and you would be able to comment as a psychiatrist much more effectively on this than I could, but there are times when I've wondered if there's even an element of projection, that we see what you just described, that, other physicians, we may have a different standard looking at physician patients and thinking, you're a physician. Why are you bothered by symptoms at this level?
Projection or denial. We don't want to accept the fact that we are vulnerable. We can have every illness that everybody else does. And when we see it in somebody else, we might tend to minimize it and downplay it because, the reality is that we're all vulnerable. So
we sort of see ourselves
and
in
we
our
have
colleagues.
to protect ourselves.
Yeah. Another thing that comes to mind is just the importance on both sides, but especially for, anytime we find ourselves in a patient role, self-compassion. Can you talk about how you coach people through finding more compassion for themselves as patients?
Oh, that's a great question. I could use some coaching myself.
Well, maybe after. I'll put you on my program.
Yes, I will. Yes, okay. I mean, people need to really take a moment to think about it. Would I say that to somebody else? Would I say that to a patient? Would I say that to a friend? Or what actually would I say? You deserve the same. I do think that medical culture tends to reinforce all of the sort of superhero ideals about physicians. So it makes it hard to accept that all those things that make us human.
If you think about the ways that your own practice has been influenced by your own experience with illness, clearly that insight is one big piece of it, what you just shared. But is there something else that you think of as having really influenced the way that you see looking after patients from your own experience?
I know that my physicians, various times, when I'd be well, and then I would suddenly not be well. And they seemed frustrated. And it was almost like, oh, I know I'm reading into this. Oh, you again. And here you are with your little illness. And now I can understand, maybe that was an identification with me, but they didn't actually say that, oh, I'm not frustrated with you. You have your illness is not being very kind to your body, and that is very frustrating, or something like that. I'm very mindful of when my patients, or even when the people that we work with at the OMA, they're not my patients, but we do provide clinical support. They're going to come back, and they're going to be upset, and they're going to feel ashamed, and we really have to manage that in a tactful way, and not let them. We don't want to. What is the word? We don't want to feed that shame.
I just found it occurring to me as you shared the triad earlier, perfectionism,
Oh, yeah.
and I mean,
Yes.
how does that influence the need or a subconscious programming, like to be the perfect patient, even though we're not perfect
yes.
patients? What do you think of that?
I have a story about that. So I think I've probably told you about my gastroenterologist who clearly overworked, very serious, and I saw him smile once. It was when I responded to the Humira. It was the first time I saw him smile. And then I started to ask him questions about it and how it worked, et cetera. And I got, he talked to me for 10 minutes. This is the most time he ever spent with me. Again, great guy. This is nothing against him. But it was very engaging. He, I think, also enjoyed being able to talk with his patient about the science behind it and whatnot. And I actually felt a lot better too, because I could engage with him on that level. But sometimes physicians don't really want to. I mean, you can talk about the science and the pathology in a defensive way, or you can avoid it because you're supposed to know already all these things about whatever it is that's happening in your body.
You just made me think of, with that story, the potential for our own feelings of inadequacy, either because we're treating a patient and things aren't going well, so our own perfectionism as the treating physician.
Well, well, it's the same thing as the minimizing the significance of the illness. It's like, well, am I a good enough IBD patient? Like, is my disease significant enough? And I would hate it when I will go and I'll, the last test I had was, I think it was some specialized ultrasound. And they would say, well, it's only up to, it's only the ascending colon. I'm like, well, okay, I'm missing my nose. Well, it's only a small part of your face. It's still like significant. So I don't really, I know what he meant to say, which was you don't have to worry about it. It's not that far. It hasn't progressed, but it's still, people have to be very careful with what they say and how they say it. That's the thing that I keep in mind most often, is when I'm, talking with my patients, I really try to be mindful all the time. How is what I'm saying being heard by them, even though my intention might be this? I don't know if that's what they hear. And it's always important to ask, what did you hear from me? Like, how did that feel for you? Or, offer an opportunity to elaborate.
Oh, I love that question. I love that question. What did you hear from me? It's not just reflecting back, but it's actually inviting the opportunity for that translation, for people to reveal something.
That's a critical element.
Yeah. I think what really sticks out for me, and it's not the first time we've talked about it, but as the message that I hear in so many of your answers, is emphasizing, just the concept that it, just like what you said with the nose, it doesn't have to be the worst for it to matter.
Very small things can cause a great deal of pain. I'll see, just if I may use an example of, physicians or anybody else with substance use disorders, there's a new rubric for deciding if somebody's substance use disorder is mild, moderate, or severe. And, it's perplexing at times, because people could have what is technically a mild substance use disorder, but the consequences can be so severe. And what do you do with that? So if my symptoms interfere a lot, but to a pathologist, they don't look that significant. Well, what does that mean? Significant for who?
Yes. Yeah, love how you frame that. It's just one way of looking at the data. It's interpreting it. That is a single lens. And yet it is the lens that it's our default lens for most things in medicine. Even the example that you just gave with substance use disorders, it's not a perfect analogy, but it makes me think of, we don't look at stage 1 cancer and say, you know what, we're just going to wait till this gets a lot worse to treat it, because then that's serious, and that's when we want to intervene. It's again, just different ways of looking, of knowing, of seeing the people in front of us.
Yeah. I mean, I know we have to weigh the risks and benefits and the potential side effects and things like that. And maybe we're not so good, actually, we're not good at all at predicting the future. But at the same time, I think we know that some things are chronic, relapsing and remitting. And I think we need to take that into consideration perhaps more frequently.
Well, Jon, I agree with you that we're not good at predicting the future, but I do know that somebody listening today, and hopefully many people today listening, have been helped by your words. So thank you so much.
Great. Thanks for having me.